We will begin. I hope you know now how to enter and how to participate in this interactive quizzes. And I hope all of you will be there because you can answer however you want. It's anonymous, so don't worry. Just tap the code and be here with us and participate. So let's begin. So I would like to take a moment and think back to a time when you or someone close to you experienced an abdominal pain. It's a discomfort we've all felt, yet behind this commonality lies a labyrinth of potential causes, some benign and others life-threatening. Today, we're not just going to talk about abdominal pain, we're going to explore the intricate clinical roadmap that transforms a patient's simple complaint into a complex diagnosis challenge. So, welcome to this presentation, Abdominal Pain, a Clinical Roadmap. So, just a little briefing about me. I'm a seventh year medical student in UISS, and I'm passionate about medicine and dedicated to helping others. No, we are not all rich, of course. I have some certificates and accomplishments. So I'm a member at an association, Les Randonneurs. I am former president of the Office of Sports and Arts and Associations, and I was a student council member. Also, I have some certificate in musculoskeletal cases and making of champion and some of it. So I did some of it online and some of it presential. So you can ask me if you want to do some of them. I can guide you. So let's begin. So are you ready for the presentation? You can type whatever answer you want. That's good. And of course, you will, along the way, the presentation, you will see in the top of the presentation, you will see the link, dementi.com, and the code to use. So if you miss it, you can just re-enter the link and just put the code there to participate. So now we will begin. So our objectives for today is to understand the key principles in assessing abdominal pain, also to identify common causes of abdominal pain and learn the initial management step for abdominal pain, and lastly, to engage interactively through quizzes, enhancing retention and understanding. So our case of today. So, in the early hours of the morning, a 58 years old male is rushed into the emergency department with severe left sided abdominal pain. He appears distressed and is clutching his abdomen, describing the pain as sharp and burning, which has become excruciating over the past few hours. The patient reports that the pain began as mild tingling and discomfort around 5 days ago, but has escalated rapidly since last night. He denies any recent injury or trauma to the area. So I'll let you see this case a little bit and then we'll go to the next slide. So let's go to the next slide. So can you list one or more, as you want, of the steps in the management of this patient? So what do you think we will do to manage this case? Just type whatever you want, it's okay. Well, the question seems hard, but the answer is easy. Okay, we will just go into the next slide. So the steps in managing these patients are 5 things we have to do. First thing is to do an ABCDE assessment, and then to do a patient conditioning plus symptomatic treatments. And of course, we have to interview this patient and do our clinical examination, and then recognize the diagnosis to consider in the presence of acute abdominal pain. Of course, if you have a patient with abdominal pain, you will have some diagnosis that will pop into your mind. So, of course, you will consider them. And of course, based on this, you will have to demand additional examinations. So this is the ABCDE assessment. We will go through each one of these that I cited. So don't worry, we will learn today how to deal with an abdominal pain. So this is the ABCDE assessment. So now some quizzes. What does the A in the ABCDE assessment stand for? Yeah, that's good. We have just one participant, so okay. Yeah, that's good. Nice. Oh, you guessed that right. Yeah, it's the airway. Our next question is, what is the normal range for heart rate according to the C in the ABCDE assessment? That's good. So as I said, it's anonymous, so you can put whatever you want. It's okay, we are here to learn today. Okay, so yeah, it was right. So this is the ABCDE. So A stands for airway, B for breathing, and C for the circulation, D for disability, and E for exposure. So here are more details about all of this. So A, it's for airway. So we do a clearing and we protect the airway. B, it's breathing. It's respiratory. Usually we have a respiratory rate between 12 and 20 breaths per minute, and the saturation is above 99 and 98. After that, we have the circulation. So, of course, a normal heart rate. We will have to see if this patient have a normal heart rate, and of course, his tension should be between 12 should be 12 18. It's if it's above 100 140, it's bad thing, and it's above in C in the diastolic. It's bad. So after this, we have the D that it stands for disability. So it's the Glasgow. So we know that the Glasgow, the best you can have is 15. And of course, you will patient and say what number according to your examination. And after this, we have the E. It's the exposed part. So if we have a patient, we really need to undress the patient so that we can see his body and really see if he has any injuries, see if he has any marks or anything that can orient us more into a diagnosis. So, of course, to do a complete examination of his body, and we have to keep it warm because he can have an hypothermia. So, of course, we have to keep the patient warm. After this, we have the patient conditioning, symptomatic plus symptomatic treatment. So in which position should a patient with respiratory distress be placed? Is it supine or prone or left lateral or half sitting? Nice, that was quick. So do anybody want to vote, or should we just go into the next one? Mhm. That's good. Okay. We have all the answers here. Okay, let's see which one should we do. 2, 3. It's the half sitting position. But it's okay. We are learning, so just remember that it's half sitting position. So this is the patient conditioning. First of all, we do a half sitting position and they monitor our patient. And we put 4 probes as needed. So we put an oxygen probe, glasses or mask, depending on the saturation. And of course, we put vascular probe, 2 peripheral venous catheters. This is systematic. But the gastric probe and the urinary catheter, it's not systematic. It depends on the case. After, of course, the treatment. So it depends on the case. So we have the resuscitation, the analgesics, antispasmodic, antiemetics. In this, you will see your patient and then you will tell what needs the most so that you can just tell the staff to do it. After they have interview plus clinical examination, of course. And this part has 2 steps in it. So we have a quiz here. Upon initial assessment of a patient with acute abdominal pain, what is your first course of action? Will you start with a patient interview? Would you begin a physical examination or look for signs of severity? Okay. Do anybody want to vote? Mm-hmm. For the ones who want to join them, just put the link you see above, mt.com, and then type the code to vote with them. Well, that's good, actually. So here is the response. We have to look for signs of severity. So I can't really say that starting with a patient interview is wrong, because in reality, you all of them together, and but you have to focus on signs of severity. So here's our first step. So we have to look for signs of severity before doing the interview or the examination, or while doing it. So the signs of the severity, we have first signs in favor of poor respiratory gas exchange. We have cyanosis, sweating, tachypnea, use of accessory respiratory muscles. So this you will see it while patient come to you, or while the patient is sitting. You can see if he has a cyanosis or sweating or whatever it is. And after this, you have to see if he has any signs of shock. So you have to see the systolic blood pressure, and if he has a tachycardia, if the saturation is inferior of 90%. And also, don't forget about the oliguria if he Glasgow test. And after this, you have to see if he has changes in the appearance of the abdomen. So of course you will do it quickly. You'll see if he has a tense abdomen while inspecting, and see if he has signs of abdominal infusion. I'm just citing examples of it, but there's a lot of things that you can search, and you will see if there is a murmur or irregular rhythm while auscultating when there is a lot of stuff there. But you have to notice this because those are severity signs and you can't miss them. After this, we have the second step. It's the interview plus the clinical examination. And in this, we will see the characteristic of the pain and how we do the anal examination. So while you're doing your interview, of course, you will search for the characteristic of the pain. And the characteristic of the pain is the location plus the radiation. You will search for it in the different quadrants. Of course, while searching for the location, I will not talk about this. I will talk about it in the examination. You will ask about the location and the radiation, and then you will ask the patient if it was sudden or gradual, and of course the time of the onset when it began. And after this, you will ask if the pain was increasing or decreasing. So it's the pattern of the evolution. And of course, the type of the pain that your patient have. Is it a cramp-like, a stabbing, throbbing? So you will ask to see. And then the factors influencing the pain. So when we talk about the factors is about asking your patient if he has an antalgic position that he can do and not feel the pain, or anything that is related to the pain that increases or decreases the pain. And then lastly, we have the associated signs like vomiting, fever, diarrhea, and constipation, and a lot of stuff. Okay. And then we will go to the abdominal examination. Of course, we have 4 components, which is the inspection, palpation, percussion, and auscultation. And we finish all of this by a rectal examination. Of course, for the palpation, you will go quadrant by quadrant, and you will not begin by the painful part. You will start with the non-painful quadrant, and do not forget to palpate for hernial orifices, even if it's quick. You have to do it. And of course, lastly, the rectal examination, as we said, it's not done. It's not always done, because it depends on the case. And of course, there is an important thing in women. You have to ask about the date of the last menstrual period, because having an abdominal pain is the first thing you have to think of is an ectopic pregnancy. So you really have to ask a woman who can still have who still can have childbirth. You have to ask her about the date of the last menstrual period, and then ask for beta HCG to confirm or to eliminate the diagnosis. And after this, there is the EKG. You don't have to miss a myocardial infarction, because as most of us know, the myocardial infarction can give you a really bad pain, an abdominal pain, especially in elder patients. So you have to ask for an EKG in this case. And then we have the additional examinations. So while having this case in front of us, we will think of certain diagnoses, and according to those certain diagnoses, we will ask for some examinations. Which blood test is crucial for assessing the possibility of ectopic pregnancy in women with acute abdominal pain? This one is easy, come on. Nice. Should we just go? Yes, it's the beta HCG. That's good. What is the primary purpose of ordering a complete blood count with platelets in a patient with acute abdominal pain? CBC is NFS. Why would you want to have a CBC and platelets for your patient? Is it to check for anemia and platelet disorders, to assess liver function, to evaluate renal function, or to diagnose myocardial infarction? Just answer whatever you want. Nice. So that was good. Yeah. It's done to check for anemia and platelet disorders. That's good. So, which radiological assessment is not typically included in the initial evaluation of acute abdominal pain? Is it the abdominal pelvic CT scan, the abdominal ultrasound, the plain abdominal X ray, or the chest X ray? Okay. Do anybody else want to vote? Like, it's fine. Just choose whatever you want. We've had enough judgments in our medical school. We don't need this here. Hmm? So it was the chest X-ray. Yeah, maybe for the abdominal CT scan and the plain abdominal X-ray, it's not always put in the first examination test, but in this case, in the abdominal pain, in some cases we can do them as a first test. But the chest X-ray here, it's not. It has no value because it's not chest pain. It's an abdominal pain. That's why. So that's okay, and I think that was good. Let's go to the next slide. So this is the recap. So for the basic biological assessment to prescribe for acute abdominal pain, we have the CBC with platelets. I put the French translation so that you can know what it's about. So first we have CBC with platelets, and then the complete electrolyte panel. After this, the ACR, the CRP, and serum lipase, and the PT, APTT. PT and APTT is TP, TCL for the coagulation profile, the ABO and RH. And of course, if it's a woman, you have to ask for the beta SCG without a doubt because it's so important. After this, we have the initial radiological assessment. So here we have the abdominal ultrasound, the abdominal CT scan with and without contrast, and the plain abdominal X-ray if indicated. That's good, I guess. Recognize the diagnosis to consider in the presence of acute abdominal pain. So let's see. It's okay, I will give you this one, and then the next one will be a quiz. The most frequent abdominal causes for non-traumatic acute abdominal pain is non-specific abdominal pain. It has 34% range, and then of course the first one that we think of when we have an abdominal pain is the appendicitis, and then the cholecystitis. Then we have the small bowel obstruction. I'm giving you those are the diagnoses that you will think of that are abdominal related causes. And then we have the gynecological emergencies. And of course, there is also the acute pancreatitis, the renal colic, the perforated ulcer, the cancer complication, and the diverticulitis. I can let you screenshot them if you want to keep them, because I know you will need this for your clinics exam. So I'll count to 5 and then go. 1, 2, 3, 4, and 5. And those are the next ones. 1, 2, 3, 4, and 5. Okay, let's go. So I want you to give me one or more main extra abdominal causes of non-traumatic acute abdominal pain. So you will give me a cause, but it is not abdominal related. It's extra abdominal, and of course it's non-traumatic. So can you guess what are the diagnoses? Yeah, that's good. You can also answer on the messages part in Google Meet. I just went there to see if you have any questions. If someone want to answer here, he can answer here. Okay, we have just one answer. That's good. Grossesse extra-utérine is related to the abdominal causes. But that's good. That was good. IC? What is IC? Can you explain to me IC here in the messages? Because I didn't understand. Okay. So those are good answers, I guess. But the most important one, I guess, is the IDM. But that's good. So here is it. The recap. Those are the non-abdominal causes of acute abdominal pain. So we have the myocardial infarction, IDM, and the coronary ischemia. Also, we have the pneumonia, the pulmonary embolism, the decompensated diabetes, and the alcoholic ketoacidosis. And for the parietal causes, we have the hematoma of the abdominal wall, the muscle strain, and the herpes zoster shingles. So you can screenshot this too if you want. That's good. Okay, so here we go back to our case. So our case, it was a 58 years old male. He has a severe left-sided abdominal pain. The pain is sharp and burning. The pain began as mild tingling and discomfort around 5 days ago and has escalated rapidly. So we've done the examinations. Can you tell me what you will do in your examination? Like, what do you want me to tell you in this examination that will help you have a diagnosis in mind? Ah, Insuffisance cardiaque. Okay. I just saw your response, Yasmin. In an acute abdominal pain, no, it's not really a diagnosis to tell. So in this case, what's can you like just tell me your questions about the examination? That you can answer in messages if you want, or activate the sound and tell me what are your questions if you want. Uh, those are I'm talking about the examination, the physical examination that you will do. Toucher rectal, no, we didn't do it for this patient. Does he have any sensibility? No, he doesn't have any sensibility. The EKG was good. He had in his par contre, in his hemodynamic part, he has a blood pressure of 150 and 19 for diastolis. Defense? No, he doesn't have a defense. No, we didn't do a CRP or irradiation. So, as we've said, it's a severe left-sided abdominal pain, and it's around the left side of his abdomen in a band-like pattern. The location. The location, he didn't really gave us a location of his pain. It was an abdominal pain, and according to this patient, it's because he did an activity previously to this, but it's not traumatic. Loss of weight, no. PA هنكتبها لك. That's good, Umayb, you're following. PNO? What is PNO? Ah, pyélonéphrite aiguë? No. So you didn't ask me about this, but I'll give it to you. He has a fever of 38.5 degree. And there is a turning point here. Results of the abdominal. No, we didn't do any further examination. We did just the physical exam. It was sufficient to know the diagnosis. So I'll tell you something. So on examination, any medication, no. The transit was normal. So I will tell you what we found. So on examination, we noticed a distinct rash with grouped vesicles on an erythematous base wrapping around the left side of his abdomen in a band-like pattern. I said rash. He had a distinct rash, grouped vesicles. Okay, now we will go to the question. I'll tell you what we found on the examination as a whole. So on the examination, you notice a distinct rash with grouped vesicles on and in an erythematous base wrapping around the left side of his abdomen in a band-like pattern. He has a fever of 38.5 Celsius, and his blood pressure is 150 90. The patient's medical history is significant for type 2 diabetes and hypertension, both managed with medication. Yeah, he has a medication, I'm sorry. He had chickenpox as a child, but has never been vaccinated against shingles. And given the acute presentation and his immunocompromised status due to diabetes, there is concern for potential complication. So, in this case. So here we go to the question. So what is your diagnosis? Is it diverticulitis, herpes zoster, acute appendicitis, myocardial infarction?
Herpes.
That's good. That's good, Rofeda. Yeah. Susan guessed that right away. That's really good. That's why the E in the ABCDE is so important. We have to expose the patient to see with our eyes what's happening because it can guide you in your diagnosis. So that's good, I guess. We will go. So yeah, it was herpes zoster. So our take-home message is always to have a systematic approach, no matter what is the case. So first, you have to be systematic and do your ABCDE. We say A for airways, B for breathing, C for circulation, D for disability, and E exposure. Don't forget the exposure. After that, you have to manage the patient, and of course you have to be conscious that you have to make your patient comfortable and not let him have be in pain. So we have to provide symptomatic relief while conditioning the patient, because we see that a lot. There's a lot of doctors who want to help the patient and do the conditioner part, but you see the patient still in pain. So we have to provide symptomatic relief to the patient, and after that we have to conduct a throughout evaluation. So you have to do an in-depth interview and clinical examination, even if it's rushed sometimes, but make sure to have the important points. Uh, and of course, you have to use the diagnosis wisely. So you have to prioritize tests based on the clinical findings to guide you, and be diagnosis aware. So know about the diagnosis that you can think of while having this abdominal pain, know know what to ask for and what to do. And of course, medicine demands much, but remember, you are capable of more than you imagine. I'm saying this to all of you because I know sometimes we feel overwhelmed and we feel like there's a lot of stuff to learn, but it's okay. As long as we are learning something, we are in a journey, and the most important part is to better ourselves each time. And I would love to have all your feedbacks because it truly makes a difference. Like, you told me a lot of things, and I tried to do my best to make it better for you. So I would love to have your feedback. It will take you 1 minute. I'll send it to you. Just 2 minutes. So here is the link. You can just go there and give me your feedback. And I'm really very grateful for your attention, and yeah, I liked your participation, whether it was vocally or by messages or by voting. It was really great. Thank you.